السلام عليكم. المحاضرة اليوم حنكمل عن الجزء الآخر اللي هو chronic leukemias. We mentioned earlier in the previous lecture with the same file about the acute leukemias and the abnormal and abnormalities in the hematopoiesis process. As we mentioned earlier, that acute leukemias occurs either in lymphoid or myeloid cell line. Similarly, the chronic leukemias affects either the lymphoid or the myeloid cell line. We have two types of chronic leukemias. Of course, chronic conditions is slow progressive conditions. If it affects the myeloid cell line, it is termed as chronic myeloid or myelogenous or myelocytic leukemias, which is immature, non-competent mature leukocytes in the myeloid cell line. Of course, it affects the other adjacent cell lines, the RBCs, platelets, monocytes, and other cell lines. Chronic leukemia is another type, is the lymphoid in the lymphoid cell line that produce the CLL, chronic lymphocytic leukemias. And of course, there's difference in the prevalence and incidence according to the age, according to the cause. The chronic myeloid leukemias or chronic myelocytic leukemias is a leukemia of the middle age. It affects people with the 50 years old plus minus, and it is a defect in the early myeloid progenitor cell, and several cell lines will be affected, of course. Defects in the myeloid cell line affect the erythroid cell line, megakaryocyte cell line, and monocyte cell line. So the patient presented with the different clinical manifestations. The etiology predominantly occurs when the patient is exposed to the environmental factors. يعني معظم حالات chronic myeloid or myelocytic leukemias occurs in the middle age, 50 decades, and chronic exposure to the environmental factors أكثر ما تكون هي genetic problem. High doses of ionizing radiation, exposure to the solvents, to the benzenes, to the asbestos, to the any environmental risk factor. This exposure will produce genetic chromosomal abnormalities, or indeed there is translocation in the chromosome 9 to 22 9 in these myeloid progenitor cells. يعني بتتعرض بالبون مارو هاي الخلايا progenitor cells in the myeloid cell line will produce there's a genetic defects بسبب الكروموسوم 9 22 translocation بين الجينات بيناتهم، وهذه الجينات it will produce certain proteins, and these proteins اللي هي PRCL and other proteins, this will potentiate and change the function of the cell اللي هي حتتكون من progenitor cell. These cells will have high activity of tyrosine kinase because of this production of these excess proteins من الabnormal Philadelphia chromosome. حيتم excess activation of tyrosine kinase. Increase in the tyrosine kinase in cells is responsible for cell proliferation and not of apoptosis. So there is increase in the hyperproliferation of these abnormal cells that contains these Philadelphia chromosome. This will present it in the blood, bone marrow, and filled in the bone marrow according to the distribution, and there can be transfused to the blood and infiltrated in certain organs. And the manifestation depends on the how percentage of these abnormal Philadelphia chromosome cells are presented in the myeloid cell or in the different leukocytes. Of course, there will be production of excess non-competent leukocytes that suppress immunity, and there is deficiency that will affect the production of the RBCs, platelets, monocytes, and other adjacent cell lines in the myeloid cell line. The clinical manifestation depends on how much the patient is exposed to these environmental factors and the duration and the presentation. So disease process in general, there is a patient presented with enlarged spleen because of this overproduction of these abnormal cells, and there's decrease in the blood count. So the blood count will be abnormal in the laboratory test. The disease passing into three stages: the chronic phase, the accelerated phase, and the blast phase. When the patient presented with the chronic phase takes years, it's about 4 to 7 years. There is a gradual raise in the level of white VCs, but there is no typical symptoms of the chronic myeloid leukemias. Because other cells remain functioning in these CML cells. يعني خاصة من هذه phenotypic chromosomes, and other cells are healthy cells. فلهذا there is low risk of infection. هي مشكلة عندنا بالimmunity leukocytes اللي هي potentiate or it is the only defense mechanisms of the body. فمن يقل number of leukocytes within the non-competent one يبدي الكلينيكال manifestations وtypical signs symptoms اللي تظهر أكثر شيء بالaccelerated phase, second phase. This occurs within months. Second phase is about 6 to 9 months. There's accelerated phase, there's unexplained fever, bone pain, decrease in platelet, decrease in the RBCs, and worsening condition. And finally, if the patient is presented with the blast phase, its manifestations are similar exactly to the acute myeloblastic leukemias اللي ذكرناها في المحاضرة السابقة. يعني يتحول من الكرونيك إلى acute manifestations، وطبعا treatment حتكون shift to the treatment of acute myeloblastic leukemias as we mentioned earlier, the induction phase and post-remission phase. So these are the disease process and the phases, and of course the response to the chemotherapy will be affected or related to the which stages or which phase the patient is presented with. Of course, the best response to the chemotherapy occurs when the patient is presented with chronic phase. ممكن يستجيب للتريتمنت ويتم survival rate cure rate كلش عالي. While the accelerated phase, there is decrease in the response to the treatment, and the blast phase, of course, there is a complete shifting in the chemotherapy and the protocol line according into the acute myeloblastic leukemias. يعني يروح العلاج myeloblastic leukemias، واحتمال patients may survival rate مو أكثر من 3 أشهر. Laboratory test depends on the blood tissue. The patients presented with leukocytosis, excess leukocytes with non-competent leukocytes, anemia, and presence of blood cells, abnormal cells in the bone marrow. And there is a high all these cells contains Philadelphia chromosome, which is high proliferated non-competent leukocytes. The desired outcome of the treatment is to gain a complete hematological and cytogenic remission, to get a normal hematological and normal blood count (CBC), and cytogenic is a complete remission in the bone marrow and restore the normal hematopoiesis. The treatment, as long as we have chronic conditions, especially in the chronic phase, patients have time to be prepared to the stem cell transplantation حتى يتم cure rate لحد 95% as we mentioned earlier. So it's the only curative، يعني the survival rate كلش عالي، يعني 5 سنين يبقى عندنا 5% فقط يصير عندنا recurrence إذا أخذنا الالوجينيك stem cell transplantation زرع الخلايا الجذعية بنخاع العظم أو بالبلاد ستريم. طبعا البيشنتس الايج هو يحدد، لازم يكونوا عمره مو أكثر من 50-55 سنة، otherwise there is a failure, a big failure in the allogenic. طبعا ما استعمل autologous stem cell transplantation لأن احتمال نفس الفيلادلفيا كروموسوم اللي موجودة بالليكوسايت will be harvested with these stem cells فيرجع يصير نسبة الريكورنس مال الديسيز تكون كلش عالية بينما الالرجينيك is the best cure rate and prolonged survival rate with patients. طبعا ما ننسى الجرافت versus disease اللي يصير لحد 10 إلى 20% ممكن يصير عندنا نسبة mortality and failure in the treatment. If the patient is not eligible to the stem cell transplantation, we can use another option, novel drugs, Clevic and other targeting cells, imatinib, danatinib. These drugs targets the tyrosine kinase inhibitors. It targets the excess production or excess activation of tyrosine kinase enzyme اللي potentiation نتيجة distranslocation of the third chromosome. فهذا ممكن يعطيني good cure rate لحد أيضا 95% تقريبا similar to the stem cell transplantation. والsurvival rate يكون كلش very efficient drug, biological drug. هذا طبعا very expensive ولازم should be provided by governmental hospitals. يعطينا good complete remission hematological بالبلاد 95%. بالcytogenics هذا بالبالماري يعطيني remission لحد 80%. طبعا well tolerated. It is better gives the best results in the chronic phase لكن less response in the accelerated and the blast phase. التريتمنت كله shift to the acute conditions with the minimum adverse effect لكن هو في enzyme metabolizer يأثر على cytochrome P450 if it is living with other drugs, especially antifungal drugs. إذا في شخص عنده fungal infection, viral infection, whatever, ممكن يأثر على metabolism of other drugs. The other options, interferon and cytarabine combinations. If the patient is not eligible or cost effective بالنسبة للtargeting cells, نرجع للother backward to the interferon of unknown mechanism, لكن it is very effective in treatment of chronic myeloid leukemias in combination with cytarabine اللي هو anti-metabolite drugs with a minimum and tolerable side effects. تبدي طبعا كل ما نروح systemic lymph targeting تبدي تظهر side effects of these medications. The conventional treatment اللي هو alkylating agents بيوسلفين and hydroxyurea هذه ممكن تستعمل. It is very less cost بالنسبة للpatients and very available وممكن تعطينا cure rate لحد 80% لكن هذه problem مالتها being very severe adverse effect and does not target the cells that possess a Philadelphia chromosome. تقتل كل الخلايا بغض النظر اللي ولا ما بيها Philadelphia chromosome with the frank adverse effect. The other type is the chronic lymphocytic leukemia that occurs when the lymphoid cell line is predominantly there is a genetic translocation in the B lymphocytes. There's a high production of excess amount in the bone marrow and blood stream of non-competent B lymphocytes. There is decrease in the percentage of the immunity in this patients. This condition is incurable disease. ما يطيب. معظم البيشنتس يصير عنده يصير بالادفانس very advanced age ويكون عندهم genetic predisposition يعني الفاميلي members لحد سبعة تقريبا فولز الريسك يزيد لما يكونوا ما عندهم relative. طبعا patient cell origin incompetent B lymphocytes accumulation in the blood stream and infiltrated into other organs and the patients presented with the persistent infection. طبعا هي الليمفويد cell line كل اللي هو المسؤول عن المناعة especially of the B lymphocytes. There is a chronic infection, immature B lymphocytes, hepatomegaly, splenomegaly, continuous chills, uncured infection and autoimmune problems and the laboratory findings depends on the excess abnormal leukocytes in the bone marrow. abnormal lymphocytes B lymphocytes أكثر من 30% موجودة بالbone marrow. the desired outcome as long as non-curable conditions وهي مو معتمد على genetic problems يعني طفرات الوراثية تصير بالعائلة. إذا the patient and especially his old age, the patient should be maintained on palliative treatment because there is no full cure. And sometimes if the patients tolerate the adverse effect of chemotherapy, the alkylating agents is the first choice as a single chemotherapy. طبعا هذا geriatric ما اقدر اعطي combination chemotherapy، فاعتمد على alkylating agents اللي ليها very wide range of adverse effect and bone marrow suppression. Chlorambucil gives a cure rate. طبعا كلها هاي الاوبشنز ما تعطيني اكثر 30 ل 40% cure rate، ولهذا survival rate كلش قليل. Chlorambucil is the first option for the treatment of CLL. If the patient cannot tolerate it or does not respond, we can switch to the fludarabine, which has a more toxicity and more immunosuppression, لكن can certain cure rate لحد 30%. The last option is cyclophosphamide, اللي هو similar response to the chlorambucil. أيضا يعطينا very frank adverse effect of the chemotherapy. كل alkylating agents major adverse effect مالتها اللي هو they can aggravate acute leukemias and هي تسوي acute leukemias. To increase the response rate and the cure rate and freeze disease survival period، ممكن يعيش فترات أطول. بدأوا يستعملون targeting cells لكنها does not target tyrosine kinase. أنا ما عندي مشكلة بالتyrosine kinase بس chronic lymphocytic leukemias المشكلة عندي genetic problem. هذه الابnormal B lymphocytes بها CT markers، بها protein on the surface. هذا البروتين have a different cluster of differentiation. ممكن CD marker 20, CD marker 52, CD marker 5 إلى آخره. إذا بدأوا يستعملون targeting cells. These also novel drugs rituximab targets any B lymphocytes اللي طبعا proliferation كلش قوي تتكاثر وكلها تحتوي على CD marker 20. فبدأوا يسووا rituximab targets these cells and kills these cells، تقتلها طبعا تروح للسبرين destruction. And alemtuzumab that targets any B lymphocytes that possess a CD marker 52. It is all these drugs are FDA approved for the treatment of chronic lymphocytic leukemias. To give a better response rate, they are combined with the conventional alkylating agent to increase the cure rate من 20-40 لحد 70% compared with the single therapy of these alkylating agents, and also to minimize the adverse and give a good response rate and prolongs the disease survival rate. This is a summary of the chronic lymphocytics and chronic myelocytic leukemias and the line of